So, welcome to PNR204 Exam 2 review. When you notice the PowerPoint, don't get upset. It's a different color. It's the same PowerPoint that you had, but I wanted a prettier color, so I changed it. I don't know, I had one of these moments this morning and I said, no, I want it to be pretty blue. So that's what I did. So don't get upset with it. Don't think it's different because we all use the same PowerPoints. Just to let you all know, there's been some talk about how can we go to a different professor's review when we're all making, quote, different exams. We're not making different exams. It's the same concepts, but different questions that ask the same things. Okay, so don't think that everybody has a different exam. They're not. It's the concept, could be on growth and development. We can ask things three or four different ways. And that's what the differences are in these exams. So I wanted to be very clear with that so that you can feel assured. I'm going to give you a review that could be for any class. Well, first of all, what we have is a bunch of definitions, and these are just your pure memorization. I always tell you, don't just memorize, try to relate it to something. So, conscious sedation is when we give drugs intravenously that put you to sleep, but you still breathe on your own. And that's the key. It's not anesthesia where you need a breathing tube. We use this a lot in the emergency room, for instance, to fix broken bones. We knock the child out and they are in a la la land. They're breathing on their own and they wake up and then they can go home that night because it's in and out of their system. Okay. Clinical pathway. This is the plan of care that tells you the treatment for the client. We have many of them. In the adult world, we have one on myocardial infarction. This is what you're going to do. This is your orders when you come in, and the daily orders that go on. It's called a clinical pathway. We know what's going to happen every day. Emancipated minor. A lot of things with pediatrics is about consents. And at 18, we know that a child who's alert, oriented, cognitively aware will sign for their own consent to whatever treatment, emergent treatment, any treatment. That child, you have to ask the parents if they can know what's going on. The parent just doesn't get information. You have to ask the child. The other one is a younger than 18s called emancipated minor. They have been given legal consent by the courts to consent for their own treatment and to care for themselves and their children. Okay. Regression. This is something which happens during separation anxiety, right? They regress, they start sucking their finger, they start urinating or and being incontinent when they're potty trained. And it's the words are it's the loss of an achieved level of functioning to a past level of behavior that was successful during early stages of development. And that's just a lot of words. What it means is they start sucking their thumb again. They want a bottle again. They want to go backwards. It's usually due to stress. Meningitis is an inflammation of the covering of the brain and the spinal cord, and it is caused by group B strep. Now, encephalitis is only an inflammation of the brain, so know those differences. Hydrocephalus is what basically water on the brain. The brain fills up with extra water in there. And one of the things in the nursing care is we keep need to repositioning these children because they can get little pressure sores on their heads with all this extra weight on it. Okay, so reposition frequently. Dyslexia is one of the things that we can have When you have trouble reading, interpreting words, letters, they're switched back and forth. And it's a very frustrating thing. And it does take therapy for them to start to be able to look at words and not switch letters around. Osteomyelitis, itis, means an inflammation or an infection. Osteobone, an infection of the bone. Osteosarcoma, it's a bone tumor. Sarcoma is a tumor. Osteo is a bone. Ray's syndrome is an acute non-inflammatory encephalopathy or hepatopathy, which means either your brain or your liver gets inflamed. It is due to giving children aspirin. Not all children will end up that way, but Ray's syndrome is serious. Any parent who wants to give their child just give them like ibuprofen or acetaminophen, give aspirin, they should be told no. We never give aspirin to a child unless it's ordered. Sepsis is a response to some sort of infection. And remember, infections can be bacterial, viral, or fungal. Okay, sepsis, overwhelming, and sepsis is the whole body responds to it. Now, we put in again about the theorists. Please go back and review them again. When we talk about Freud, it's psychosexual, anything sexual, oral, anal, phallic, latency, and genital. And latency is, I mean, I don't know why they use the word or why he did, but that's same-sex peers are your friends. You usually don't have girls and boys and girls as friends. It's usually girls or boys. So just go ahead and go through that again. Now, breaking down Freud. So, orality, the first step, that infant stage, what is oral? Well, what does an infant do to soothe themselves? They put something in their mouth, a thumb, a finger, or a pacifier, right? And that sucking is a stress reliever. What do they do with toys? What do children do with everything? Everything in their mouth. They explore the world through their mouths, don't they? Anality is all about potty training. And it's all about children saying, no, 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 mine, me do, and they don't share. Anality has a lot to do with the potty training and their bowel training. The phallic oropodal stage has to do with being aware that there are girls and boys and you have different parts. Latency, as I said, is your same-sex peers. Now, Piaget is all about thinking. And it's all about thinking and then building upon a subject. For instance, you give an infant a rattle, and initially it's a reflex grasp, and they grab it. And then eventually they do a voluntary, they just grasp it themselves. And then something happens and they move their hand and it shakes. And they go, ooh, I like that. So they do it again and again and again, right? Then, of course, it goes in the mouth. Part of Piaget is understanding if they see a toy, even though they can't see it, it's somewhere, and that's object permanence. And then it goes on into thinking about learning and being able to apply that learning. Now, we don't apply it until we're school age children, which is concrete operational. And the concrete operational is think about your house is concrete, you can touch it, you can feel it, which means children that are school age have to see it, feel it, touch it to understand it, to use whatever the concept is. Somebody else said that and it worked, so I'm going to say it too. Now, formal, the fourth stage, is all adolescents. They don't have to see it, know it, or heard it before to be able to figure out a story to get what they want. I always say adolescents can fight their way out of a paper bag and they know what they need to do to get what they want to do. Mom said, I can't go out Saturday night, but if I do this, and this, I know she's going to let me. They know what to do. And that's formal. They very logical. So this is all what I've just said. Sensor and motor is your object permanence, and it's all about exploring, shaking that rattle, and then that toy that's hidden. Then it goes into figuring out how that there's reds, there's shapes, there's cars, there's we can put them in orders now, basically. And then concrete operational is thinking, things like I'm sick because I went out in the snow, or I'm sick because I went to bed with wet hair. And it's all about, I must have done something wrong for this to happen to me. And as I said, the formal is all about they can figure anything out to get what they want. And that's just Erickson and the names. Know the names of these and basically what they mean. Remember, infant is all about trust. They can't do anything for themselves. They trust when they cry, somebody's going to come take care of their needs. And the mistrust is when the people don't come. Goes on into toddler and it's autonomy. What did I just say about toddlers? Me, mine, me do, no share. They want to be autonomous. They want to jump off the couch onto the other couch, not thinking it's too far away and land on the floor and crash their heads, right? No, that's mom and dad and grandma and grandpa saying, be careful and don't do this and you're going to hurt yourself. And wait, I'll do it for you. That's the shame and the doubt, okay? Those two are very commonly seen on many exams. Good understanding of them are good. Also get into school age. Industry is that house that I built that I do well, whether I'm good at spelling, playing the piano, running, whatever it is. And the inferiority is the things I can't do because I can't do everything right or well. And adolescence, body image, identity, who am I? And then it's that role confusion. I don't know what I want to be. I don't know my body image. I don't like trying to figure out all of those things. I don't want to be an adolescence again. So again, it's just what I said. Infants, it's trust. They know somebody's coming when they cry. Toddlers doing things all by themselves, but someone telling them, be careful and don't do that. And that's the shame and the doubt. Preschoolers, like it's the initiative. They try to do things, but then they get criticized when it isn't completely right and they get frustrated. Therefore, it's the guilt. School age, they do things well and some not. So their industry, their house, I do this task well. The inferiority, I can't do it all. And of course, the adolescence, body image, my role. Who do I like? Girls, boys. Do what do I want to be when I grow up? I want to be a football player. I want to be a doctor, a lawyer. What is it? I'm trying to figure it out. And then who do I fit in with? Maslow's always starts with physical needs. That physical needs are what you need to live. And then the in between is that safety and needing love, etc. But the top is when you feel good about yourself. That is esteem. Goldberg, this is all about right, wrong, and there's a consequence for each. As they get older and get into like the school age, they want to do the right thing. They don't want to be punished. And then as you become the adolescent, there are rules of society and they know they have to follow it because that's what society dictates. So the hospitalized child, kid gets into the hospital, what are we going to do for these children? Well, when does discharge planning begin? From the moment they walk in the door, right? I always, as I'm doing things to a child, I'm talking out loud. It's also for the child because even young children know what you're doing and they can help parents take care of themselves too because now they hear the nurse saying it. And it's also for whoever's at the bedside with them to decrease the anxiety of a child, especially cognitive delayed and those toddlers have those parents stay at the bedside. They don't, what's going to happen? all the screaming, yelling, crying, separation anxiety. And you just did a really good discussion question on that. When you see a child that's a little bit confused, that altered level of consciousness, and there's no other medical reason for, they're not getting perfusion to their brain, right? So it's low blood pressure. Take vital signs, get the blood pressure, and do your temperature, pulse, respiration, and your O2 sat, but you're going to see a low blood pressure most likely. So, goals for caring for a hospitalized child, what are they? Well, it's family centered care. So, you're not just taking care of children, you're taking care of the parents or the significant others that are there with them, and you need to let them know exactly what's going on. We are lucky today that physicians don't have to be the one that tell these parents or children everything. As nurses, we can be autonomous in that. And I love that part of nursing, that teaching. Let them know what's going on. When you're working with a child and you're going to do a procedure and it's going to hurt, be honest. For instance, if you're going to take a child and do, let's say, a lumbar puncture, and they're on their side, when they put that needle way, way in, it's going to sting a second. It's better for them to be prepared. And I, at that point, I'll have them positioned. I'll be holding their hand. And I said, it's okay. Squeeze my hand if it hurts. Just don't move. And it's only for a second. And they actually, when you say, we'll give you all the medicine we can, but it's going to hurt a little. I'm telling you that trust that you get is good. They know that not everything is, not going to hurt. They know something's going to hurt. Remember, every child is different. And this is why I love pediatrics. The way they act, they respond to things, they're all different. So be aware of that. Try to incorporate home routine, home schedules, especially your younger kids, your cognitively delayed children. These children, to put the home routine, they know what's coming next. When do they wake up? When do they get dressed? When do they take a bath? Foods that they eat if they are capable, depending on their conditions. Those things make a child less stressful. Sometimes when we have to do a painful procedure, like let's say that lumbar puncture, use play. It's great today. They have these people called child life people, and they come in and they're highly educated, a minimum of a bachelor degree, and they know the developmental levels of children, and they show them all the things. Now, if they're doing a lumbar puncture, we're not going to show them that 3-inch needle. I mean, no, we're not doing that. But we will tell them we'll be touching here. Okay. We can show them what the tray looks like, the way they'll be positioned. And then we'll, of course, use all those distracting things that we need. And then they can play with the gloves, and, it just makes it less threatening. I mean, the mask that they're going to wear, the whole thing. Always try to, after procedures, surgery, try to get that kid back to his normal baseline. Kids are happy there. They don't want to, kids are great. They're not the type that, oh, I hurt, I moan, I had surgery, it's 2 weeks later and I still hurt. Kids don't do that. Get them up, get them out, get them moving, within what the doctor says. And, each group of children are slightly different. So at 6 months of age is when we start to see more separation anxiety. This is those three stages: protest, despair, and denial. The protest, screaming, yelling, crying. And it starts about 6 months, and by almost a year, 10 months, they're really aware. Parents aren't there, and it's hard on them. So how do we as nurses, we're left with the children. Parents have to take care of other kids. They've got other responsibilities. They have to work. I mean, this is a reality. So we're left with those children, and we need to do things to help them. So, number one is make sure that if a nurse is on 3 days in a row, that nurse gets that child so that they know who's coming, because different people every day, that's confusing. When they parent leaves, don't let them stand there for an hour saying goodbye. It's okay. Do it as quick as possible and get out. That's easier than a just really long goodbye. Distractions. Put on music, put on TV, give them a iPad, sit down, help them color a picture, do all of those things. And then, of course, reassure that child that they're coming back and tell them in the child's developmental level. Young kids, mommy will be back tomorrow after you wake up from your afternoon nap or after lunch or before dinner tomorrow, after the sun comes up tomorrow. These things they understand. They don't understand 5 o'clock tomorrow, mommy's coming. So make sure it's in that developmental level. Again, always have those familiar objects around: toys, jammies, pillows, stuffy animals, blankets, whatever it is. They really need that. They need that comfortable stuff. And again, it's all about building that rapport with that child, that nurse, and it's going to help bring that child when they finally come back, that child will reattach to their parent. Pain scales. Nonverbal children and children, infants up to the age of 3, is going to be a FLAC scale. And the FLAC scale measures the face. What does it look like? Is it grimacing? The legs, are they moving? Are like they going crazy or just laying there? Your activity, your crying. How bad are you crying if you're crying? And then can I console you? And it will add up to 10. So this is one of those things that you just add the numbers up and it will give you from 0 to 10. It will give you a scale number. Now, at 3, up to age 8, and sometimes longer, sometimes less, but according to the book, at 3, we're going to start using these lovely little faces. And children at 3 will point to the one they are. And children don't lie when it hurts. So it's a really good tool to use. Pain scales, knowing children have pain, and then making sure that we medicate them. Remember, whatever a client says their pain is, it is what it is. You can't argue with it. There are children and adults that are in pain that are sitting there joking and laughing because that's how they deal with it. So, not everybody's the same, right? How do we best administer pain management? Well, it's better and more effective when we do low dose analgesic around the clock regularly, not just whenever the pain peaks too high. We keep it on, that in between level where it's not so severe and it works better. Acetaminophen works well. I mean, we do that for post-op tonsillectomies, and it works well with pain on children. They're not used to a lot of, acetaminophen or ibuprofen. They're not used to it, so it works. It's mild to moderate. Now, kids got a big broken bone, sickle cell, cancer. We're going to use opioids, morphine, for example. It's moderate to severe. When we're doing certain procedures, starting IVs, doing that spinal tap, lumbar puncture, we're going to be putting lidocaine there. And either it's rubbed on, okay, and then we inject it in there, or the IV, there's this little thing that just squirts. It's like by pressure. It's where I used to work. It's like a little gun. It was in a little syringe, and you push a button, psh, it would go into the skin, and it would numb the area. And it really helps. You're going to feel touch, but you're not going to feel pain. It works. I've already said conscious sedation. It's when they are asleep, but they're breathing on their own, okay? Flumazenil. Does anybody know what that is? This is for reversal of benzodiazepines. Now, what's the reversal for your opioids? Narcan or naloxone. Those are two things that you'll see questions on, whether HESIs or whatnot. Those two are always, they love picking on them. Okay, eyes. Eyes, many things can happen with them. A lot of times, children get what we call pink eye, conjunctivitis. It's that green, goopy debris that's coming out. The mucous membranes all inflamed, and it's very common in school and daycare because kids touch things and they touch their eyes, and it just goes around and around. Hyperopia is farsighted, which means I can't see here. And myopia is nearsighted, which I can't see across the room. Why they do it that way, it's so confusing. It's opposite of what you think. Amblyopia is when one eye, sort of the muscle is down and the eye's not straight like the other. And we treat that by making that lazy eye work. We cover the good eye with an eye patch periodically through the day, and we make that bad eye work to strengthen that muscle, and it works. Strabismus. Both eyes are still seeing by their own. They don't come together and see it at the same time, and that's called strabismus. Nystagmus is that wiggling. Your eyes sort of twitch and they jerk. Papilledema is when your optic nerve gets edema on it and causes visual problems. Now, ears. Today on discharge, all newborns get hearing tests. But there's all different ways loss of hearing can occur. Well, at birth, if they don't hear, that is called congenital hearing loss. It could be hereditary, could be loss or lack of, the ear itself, or it could be an intrauterine infection. The sensorineurohearing loss is when the hair cells in the cochlea and the nerve are damaged. So that's sensorineuro. And then conductive means that's going from place to place. So that doesn't allow the tympanic membrane says, nope, sound, you're not going to the middle ear. And that's where you're here from. So, what do if you have a child who's hearing impaired? Well, these children, many of them can see your facial expressions and the way that you're talking. So, always face to face and not above them, eye level, okay? And look at them with your eyes and talk in short sentences. You can talk as loud as you want. They're not going to hear it. So just talk normally, okay? Two types of ear infections. We have otitis externa and otitis media. Well, otitis externa is the external ear canal, and we put antibiotic eardrops in the ear. That's how we treat it. Otitis media is inside in there, and they're always bacterial. So, how do we treat it? We treat it with antibiotics. A good one is amoxicillin, right? Seizures. I describe seizures as something in the brain all of a sudden gets upset and sparks, and it creates weird movements, or just stares, twitching, blank, just sitting there, many things. It's that uncontrolled electrical activity, and it makes the body do things it shouldn't. There's grand mal, petit mal, Jacksonian, myoclonic, and status. What's the difference? Well, Grand mal is what we think of with a seizure. Arms and legs going, usually foaming at the mouth, bladder, maybe bowel also, loss of control. And then after this grand mal, there's a period that we call postictal, which is they're sort of sleepy and they, what happened? Where am I? Type thing. A little confusion. Petite mal could be just the twitching of an eye, could be a blank stare, and it's only for short periods of time. Jacksonian is like a partial seizure, and this one could be just that one arm going, one leg going. Myoclonic is, or atonic seizures. It's jerking motions on awakening. And you get up and you have a seizure and then you fall back down. And you're, uh, you're collapsed for up to a minute. And then there's status epilepticus. This is a prolonged seizure that does not respond to treatment for 30 minutes or more. And that is scary. We treat it with a benzodiazepine like diazepam. And then a lot of times we give them some sort of seizure drug, could be that phenytoin. And our concern always is airway. So turn them on their side because they're going to vomit too, right? Have suction there. And I've already said what postictal is. So, what causes seizures? A lot of stuff, right? Infections, fever, drugs, epilepsy, and hypoglycemia. This is low blood sugars. All of these things can cause it on any age children. So, as nurses, we get a child come in with, seizures as his diagnosis. What do we need to do? Well, keep the side rails up. And if at all possible, we can pad, whether it's with pillows or blankets, or sometimes they have these pads that go on there for seizures. Have it all soft so that they, when start bouncing their arms and legs, they're not going to hurt themselves. Now, nothing hard, nothing sharp in the bed. No toys like that there, okay? Because if they start seizing, they're going to rub on it and they're going to get hurt and they're going to get lacerations, etc. As I said, suction should always be there. We're going to turn them on their side because they're going to vomit, and we can have suction there to keep that airway clean, and that's what it's there for. Not to shove it in their mouth during the seizure. No, it's just to get it on the outside so that they can still breathe. One of the things that can cause seizures from happening is lack of compliance. These parents need to be taught that they need to give medications as told, follow up, get the drug levels as ordered so that we can keep them from having seizures due to not getting their medicine, right? And
That's
one of the, yes?
if you don't, say for instance, you've been taking Keppra for a long time, and if you stop taking your medication, what are effects that could happen if you stop taking it? I was
Well,
just curious.
there's all things. You could have rebound seizures on that like crazy.
Could it
Or
still be
you have
vertigo?
none. It could have gone away. You don't know. But it's to take the chance of having these big seizures. And usually they don't just take you off something, they wean it down
They taper.
slowly. Yes, they taper it. Yes.
Okay.
Okay. One of the things with children is they can't be somewhere alone that they can be dangerous, like swimming. If they're out swimming, have a seizure in the middle of a lake, a pool, an ocean, who's going to get them? So make sure that somebody always is going to be there watching them because it does and has happened. And again, medication, what type, it's all about the type of seizures, et cetera, et cetera. And they always start slow and they go up and keep adding until they can control those seizures. So, meningitis is an inflammation of the brain and spinal cord. This is Haemophilus influenza. Also, Bacterial is causes this irritation, and then all of this toxins and stuff go in there. And then it causes that meningococcal, and that's when you get all of the neck rigidity, etc., headaches that go on. Now, with meningitis, they need to be placed on droplet air sort of isolation. They put these in reverse airflow rooms, and they can start antibiotics, and then after 24 hours on, they're not that infectious as they were with no antibiotics. So they say after 24 hours, it's safer not to wear a mask. I mean, I always would, but that was me. But according to guidelines, 24 hours, you really didn't have to. With meningitis, you got a brain that's inflamed and you got a spinal cord that's inflamed. Do your neuro checks, making sure you check the pupils and the limbs and confusions, et cetera, et cetera. And anything that you see, if they're not acting right and confused and they're falling or can't talk or can't express themselves, these are things, something's going on in the brain. Let the doctor know. We measure vital signs, of course, but intake output's very important. Can you imagine now overloading fluid into the body with an already irritated, with all of this bacteria, toxins that are in there? Put more fluid in the brain. It's not what we want. So intake and output's very important. We don't want a fluid overload. And that meninges is so irritable. You want a nice, quiet, darkened room because the headache, the stimulus is what we would really hurt them. So we have fractures, sprains, we have strains, and kids are always doing something. It's just what they do. They run and they play, and things happen. So green stick is, let's say you have an arm and or a leg and you've got two bones, right? So you have one side of the bone is broken and the other is just bent. And that could be one bone or it could be two bones. Compound is when that bone sticks out of the skin. And this one we have to be placed on antibiotics because of chance of infection. Once a bone hits the air, it's infected. And it could be osteomyelitis, right? So we really need to be careful, start antibiotics. Simple fracture, the bone is broken, but it's inside. And we just usually, make sure it's correctly placed, put a cast on it, and it will heal. Oblique fracture is an angle, not just a break, okay? A simple. Spiral is when you grab a kid's arm, let's say, and you twist it. And this is usually seen in child abuse. You're going to see it twisted. And one of the things at that point is now you're going to investigate. Get the child alone, get their story, get the parent, alone, get their story. It doesn't match because as nurses, we are responsible to report this. I've had many abuse cases come in that I have seen that we made sure the child is safe. I've had all different things. So remember that if you suspect, tell your charge nurse, tell the physician, depending on what, where, and how you're working. Okay. Sprain. I've had 100 of these playing sports in my lifetime, especially in volleyball. The ligament is torn and stretched away. You come down from trying to hit the volleyball, come down, and your ankle twists and it goes, and immediately it starts to swell and bruise and it hurts. I think that hurts more than a fracture. Strain is when you're doing something repeatedly, repeatedly, repeatedly. I remember walking one day in an airport from number one gate up to 66, and I had to go back to number three, and those little things that move weren't working. And I remember the front of my legs had these strains. It's that overuse. Could be those athletes like gymnasts, ballerinas. These people are going to be getting those sort of things. And then a contusion is a bruise. It's a tearing of the tissue, which tears the blood vessel and it causes that big purplish area with swelling and it hurts. So those are your sort of fractures. And there's pictures that you can see them and you can go back and to relate it. So bones, things that go on with them. Scoliosis is an S curvature of the spine. And what you see, it's usually at that pre-adolescent, 12-year-old area where they start to grow really quick. It's this growth spurt that they call it. And you look at them, and one shoulder is higher than the other. The scapula sticks out, and one of the arms is longer than the other when they bend forward. And you can see it. They treat it with exercise and a brace. Ewing sarcoma is cancer, and it's in the bone marrow of long bones. Leg calf Perth is a basically an aseptic infection. So it's not, it's an asepsis irritation of the head of the femur, and it's lack of blood flow to it. And it's for no reason it happens. And in rest and just giving bed rest, it does heal by itself, and usually it heals. JIA, JRA, whatever you want to call it. Um, I have I have rheumatoid arthritis. And what it is my body, and it happens, I've seen it young as 3-year-old children that were complaining of pain, and we figured this is what it is. My body says, joints, I don't like you, let me attack you, and they become swollen and painful, and it hurts. Now, it also can go to connective tissues and viscera. You know, I get these sometimes in my abdomen. It's like that viscera gets stuck, as I call it. Oligoarthritis is 4 or fewer joints. Some people have just the knee that hurts, or just the elbow, or the wrist, or a finger. And there's people who are all over. So oligoarthritis is 4 or less. So that is different. Osteosarcoma is a primary malignant tumor of the long bone, and osteosarcomas require that whole, it's usually a femur bone, that whole femur bone to be removed. Duchenne muscular dystrophy. In boys ages 3 to 7, it is this progressive muscle deterioration. You will see big calf muscles on these children. They'll be waddling, they'll be weak. It'll get to the point where their muscles don't work. And then around teenagers, the heart muscle and the diaphragm muscle stop working, and that's how they die. Torticollis is that stiff neck, when your neck is stuck to the side and doesn't move. The sternocleidomastoid muscle, that SCM. Bucks traction. Have you ever seen bucks traction? A lot of students have seen this in fractured hips of the elderly, but we do use it in children. And many times we use this for a fractured femur before they go to the OR and get it fixed, okay? Now, they take it, this boot, so there's no metal pins, nothing stuck on them. Put a boot, put it on the end, the calf of the leg, and it goes up over a pulley, and a weight goes on the end. And it pulls that femur. So those little fractured areas that are trying to touch the muscles and nerves, and it hurts, it's straight. So now they're pain free till they get to go to the OR. Bucks traction, skin traction. So the purpose is to keep that leg straight and to keep that normal length so you don't have a shorter leg. It reduces it. It eliminates those muscle spasms and those nerves. They're not touched, so we don't have that pain. And it does help with reducing a reduction of skeletal abnormalities. When you have a fractured something, you always look distally, right? If you have a cast on your arm, you're going to be looking at the fingers and the radial pulse, right? We're going to check the pain. A little pain's expected, but a lot of pain isn't. So, is it pain, pulse, pallor, paresthesia, paralysis? The pulse, is it gone? Is the color not good? Capillary refill's not good. Is it getting numb or I can't move it? These are all signs that they need to get back to the doctor to check that cast. It's too tight, usually, okay? So we need to teach our families and the child what the thing is. I mean, even with Buck's traction, we need to be doing neurovascular checks regularly to make sure that that bone didn't slip, occlude a big artery, and stop blood flow from going back to that toe. So it's always neurovascular checks, orthopedics, they go hand in hand. There is cervical traction. There are tongs we can put in called Crutchfield. That's for your fractured necks. And then they don't do it like they did before, but a Steinman pin was usually put in to the leg when you had fractured femurs. And they used to keep these children in the hospital for a month with this Buck's track, like the traction, the pulleys and the weights. But today they're putting metal rods in the femurs. So Steinman isn't used as much, but they still use the cervical and the Crutchfield where they're trying to keep that spinal column, that cervical spine straight. Cerebral palsy. It's a disorder that affects the movement and muscle tone or posture. This is caused by some sort of damage in the immature brain. Sometimes it happens before birth or during that birthing process. Somehow oxygen was delayed, and I've seen it where after born they had an acute hypoxic episode, and that can cause decreased blood flow to the brain, which can cause cerebral palsy. It's from very mild to very severe. Usually you think cerebral palsy, you think of the child in a wheelchair with spastic, where they're just, unable to control themselves at all. But in cerebral palsy, all of your reflexes are abnormal. You can be floppy or rigid. I've mostly seen rigid, but it's that abnormal posture. You have to strap them in a wheelchair because they'll slide out easily. They have these involuntary movements. Some can walk, but they need usually some sort of walker to help them get around. Some of the key terms that you have to know. Now, I did mention that stiff cerebral palsy child. That's spastic cerebral palsy, and it is the spasticity that we're naming it from, which is that stiff, jerky movement. I mean, my little Jonathan, where I did clinicals, he'd see me and he'd put his hands up and he would get so tense and tight just because he wanted to see me. So that's the spastic. Now, aphatosis is this involuntary, purposeless movement that interferes with child's motion. Like they try to do something and they can't get there, and their hands don't work the way that they want. That's aphatosis. And then opisthotonus is where they arch their back. And the picture is perfect. And it's just muscle contractions and they arch back. So those are your three key terms with that. Now, as I said, child abuse is real. It happens. And what are some of those things that could cause parents to or whoever to inflict abuse on their children? Well, it could be a child who is disabled, temperamental, hyperactive, or it could be a child that's step or foster. It could be some of the things that, you're really hard up with money, you don't have it, and you're struggling hard, or you just lost your job, or the family's dysfunctional. Mom and dad don't get along, or are breaking up. Those things can cause it. Parents that have been abused as a child are more apt to abuse their own children. Low self esteem, or when they're so overwhelmed, overworked, they just take it out on their child. Could be uneducated, and substance abuse always is a trigger with that. So the triggers is, they need to discipline, and then, this things happen. Conflict in the family, take it out on the kids, or it's that substance abuse. Of course, there's the kids. And then financial crisis, of course, money always is, a big stressor. Now, there are several types of child abuse. It's just not all inflicting pain. There's that emotional one. That's one of the hardest ones to determine, that the parents are just talking that you're dumb, you're stupid, you'll never be anything. It's that verbal acts that destroy those self esteems. And it happens. Emotional neglect is when they don't get the love they need. No hugs, no nothing. It is that intentional omission of those verbal or behavior actions. Sexual abuse is when the child is abused somehow for the gratification of the adult, not the child, and many different ways of child abuse. Physical neglect is when they don't get the things they need: food, house, clothing. That's physical. And then, of course, physical abuse is when, they are hit and they're abused. Now, you're going to have 5 dosage calculation questions. You do all have my review that I've sent out. If not, go to Professor Bogart, Pediatric Nursing, scroll down, find what you like, open it up, and review it. I make dosage calc so easy for you. Okay? Any questions?
Nope.